I'd like to thank the organizers for giving me the opportunity to speak. Actually, I'm not sure I need to give this talk after those 3 wonderful talks. I think they solved our problem and answered this debate. But I'm anxious to have this opportunity to give my side of why we definitely should be doing NGS testing for all GI cancer patients. These are my disclosures. I'll highlight the fact that I'll be discussing off-label use of approved therapies almost by definition for this talk. Trying to frame the discussion here and why I think that there is value to doing NGS testing for all advanced cancer patients, I'm going to focus on the reality that all GI cancers in general are very deadly, treatment for it is expensive, and I'm going to dispel the notion that testing does not reveal actionable mutations. In fact, in GI cancers it very often does. And then most importantly, that finding these actionable mutations and treating patients appropriately actually leads to a disproportionate benefit, even potentially to survival benefit. So let's walk through it. I don't need to tell this audience that advanced GI cancers are deadly. There's more than 3 million patients in this world that are diagnosed each year. It's one of the most deadly cancers that exists. And while there has definitely been progress in standard therapies over the last several decades, the progress is incremental. I don't want to make it seem like I don't believe in standard therapies. I use it every day, and I definitely have seen the benefits to standard therapies, particularly over the last 10 years in pancreatic cancer, every day in treating patients. But these benefits, these improvements are truly incremental, and I highlighted 3 studies here where therapies that led to FDA approval of drugs really were approved based on survival benefits of less than 2 months. So for example, TAS-1 and 2 in colorectal cancer had a 1.8-month median overall survival improvement. Gem/Nab-Pac, which I use routinely, only has less than a 2-month median overall survival improvement. And ramucirumab also was approved for gastric cancer, again, less than 2-month benefit. And this comes at significant cost. Looking at these same 3 trials and focusing on these same 3 drugs or drug combinations, these are expensive drugs. Many of the discussions that we have about whether we should be doing NGS testing focus on the fact that, oh, NGS testing is very expensive. Well, look at TAS-102. For 1 month, it's $10,000, $11,000. For Gem/Nab-Pac, it's $12,000. And for ramucirumab, it's $15,000. Whereas one retail test, and I do emphasize retail testing because, of course, nobody pays retail, but one retail test for an NGS panel costs about $700-800, which includes the RNA fusions. And that price is going down significantly. There are now companies out there, and certainly in-house panels that are being done for $1,000 or $1,800, much, much less, and certainly much, much less than the chemotherapies and targeted therapies we're using for our GI cancer patients. The other really big hurdle to really sort of tamp down is that indeed, GI cancers do harbor actionable mutations. If we define actionability based on the fact that literature supports a high degree of benefit in patients who have that specific biomarker and are treated with the appropriately targeted therapy, but emphasize that that exists across any disease type, then that's really where our definition of actionability can be applied to GI cancers. Because in many GI cancers, targeted therapies are not yet approved. And in that context, actionable mutations are found in every GI cancer that we've studied. In pancreatic cancer, as I'll show you, about 25% of pancreatic cancers harbor actionable mutations. It's 20% in biliary cancers, 30% or more in upper GI cancers. And in colorectal cancer, it's probably 10%, but actually when you factor in RAS and RAF, it's more like 80%. So let me give you some specific examples. This is from our Know Your Tumor data set, but actually in all honesty, there's about 8 to 10 very large, very important publications over the last 5 to 6 years that have looked at pancreatic cancer patients comprising more than 5,000 individual patients. And every paper shows consistently that about 25% of pancreatic cancers harbor actionable mutations. You see the list here on the right. The majority of these findings are in the HR-DDR pathway that Dr. Golan just discussed, but in reality there's also several other smaller slices of the pie. 1% of patients with NTRK fusions or ALK-ROS fusions, about 4% of patients who have some form of BRAF alterations, and the others that you see down the list. So these do occur in pancreatic cancer and can be targetable. Another example is in biliary cancer, where in some cases in some reports up to 40% of biliary cancers harbors these so-called actionable mutations. This is a really nice summary from Dr. Jane and Javli, an image from their paper that really describes that in each specific cholangiocarcinoma subtype, they have different mutational patterns. I summarized it here. This is their data, but I just summarized it into a table to get a better look at it, where you see that in separating the 3 different subtypes of cholangiocarcinoma, you have, for example, 10 to 20% HER2 amplification, 10 to 20% FGFR amplification or fusion, and up to 30% in the case of intrahepatic cholangiocarcinoma of IDH1 and IDH2 mutations. So we identify the mutations, what about actually acting on them? And what we have seen consistently is that when a biomarker is present and the correct therapy is available and is given, that these patients benefit disproportionately. Thus far, most of these have not been targeted with FDA-approved therapies, but we're starting to see the leading edge, the vanguard, if you will, of the disease-nonspecific biomarker-approved drugs that have really been taking the lead in showing us how to develop these studies. So the best example still to date is Young Lee's work with pembrolizumab in MSI-High tumors. This is from her science paper where it shows that the majority of patients who have MSI-High tumors, many of which are GI cancers, benefit dramatically with pembrolizumab, and we know similar data exists with nivolumab. Another FDA-approved disease-nonspecific but biomarker-directed therapy is larotrectinib for NTRK fusion, different kinds of cancers. I highlight here with the red arrows specifically the GI cancers, but you really see clearly that the vast majority of patients who have an NTRK fusion and are treated with this TRK inhibitor, they benefit, and in some cases there are PRs and sustained CRs. We presented one small case series of 3 patients with pancreatic cancer with entrectinib, the sort of close cousin of larotrectinib, and again showed dramatic improvement in patients, sometimes very rapid, when they were treated with entrectinib when they had an underlying NTRK or in one case a ROS1 fusion. And this PET scan that you see here is an example of a patient who actually within 1 month of therapy went from being very close to hospice to actually having a dramatic clinical improvement. And as far as I know, to my knowledge, that patient is actually still on entrectinib now a couple of years later. This is also becoming true for other therapies that may or may not be yet FDA approved, at least in these disease types. One example that we know of is with BRAF V600E mutated cancers. This is data from the safety lead-in study of the Beacon trial, but we know just from recent press reports that the Beacon trial is a positive study. And again, like with pembrolizumab, nivolumab, and MSI-High, like with larotrectinib and entrectinib and NTRK fusion tumors, you see that the majority of these patients who have a BRAF V600E mutation and are treated with Encorafenib, cetuximab, and binimetinib, that they actually benefit from this kind of a combination therapy. And in diseases outside of colorectal cancer, we're also seeing this be true as well. In the Know Your Tumor database, we looked at our 766 patients at that time, found 18 BRAF mutations, 5 of which were V600E patients, and we were able to get one of the patients treated with MEK inhibitor-based therapy, with dabrafenib and trametinib, and actually this patient had a sustained PR with this combination therapy. And we heard yesterday at one of the talks that there are also biliary patients who have similar mutations, again, who are benefiting. So this evidence is accumulating. There's several other examples I'll highlight here. The Heracles trial for HER2-amplified colorectal cancer, where they did a wonderful study screening 900 patients, finding 5% of the patients who are HER2-amplified. And this is a very heavily pretreated patient population. These patients would have gone on TAS-102 or regorafenib, and we know with single-digit response rates. But in this heavily pretreated population, there was a 30% response rate, with some of these patients having durable response. And we just heard a minute ago, actually one of these patients is still in a CR several years later. And then we've heard more and more about FGFR amplifications being targeted as well, and fusions with FGFR inhibitors. Again, very disproportionate benefit in this patient population. One of our focuses has been on HR-DDR mutated pancreatic cancers, and I'll go through this quickly because Dr. Golan just did a great summary of it, but we did see that about 17% of patients in the Know Your Tumor database and also in the CARES database harbored some form of an HR-DDR mutation. And when these patients are treated appropriately, either with a platinum-based therapy, they have disproportionate benefit compared to non-platinum-based therapy, or with newer PARP inhibitor-based therapy. There's been anecdotal evidence growing that PARP inhibitors will benefit these patients. There's been PRs and CRs observed in a patient population, in this patient population. And I'll highlight Dr. Schroff's data, if my marker works, of the RUCA-PANC study, where 19 BRCA1/2 mutated patients were treated with rucaparib. There was a 16% objective response rate, including 1 CR and 2 PRs. And Dr. Schroff highlighted the fact that there were actually non-germline BRCA mutated patients, so somatic BRCA mutated patients, who also benefited from this therapy. So it doesn't just have to be the germline patients. In fact, the most important predictor for response in this particular trial was prior progression on platinum-based therapy led to an ineffectiveness of rucaparib. There may also be synergy for targeting these patients with PARP inhibitor and platinum-based therapy in combination if it can be safely given. We're all waiting eagerly for Dr. O'Reilly's randomized phase 2 trial of gemcis plus or minus veliparib, but in the phase 1b safety lead-in study, there was an 80% response rate in this patient population with a 23-month overall survival. And we just saw yesterday Dr. Golan present the POLO data in the germline BRCA mutated patients where there's an improvement in median progression-free survival as well. So this is a viable platform for treating these patients when we actually find them to treat. The question is that next, do we do single gene testing or do we actually do multiple genes or we just do a panel? And actually I look to our lung cancer colleagues who've really led the way in this. And Nathan Pennell did a great analysis looking at a model of non-small cell lung cancer where testing EGFR and ALK and ROS is absolutely critical. And their study looked at an NGS panel versus sequential gene testing versus other platforms. And what they found was that really the time to test results and importantly the cost was actually less when an entire panel was used. They looked at gene testing costs, at least in the United States, for both Medicare insured patients and for commercially insured patients. And when you look, for example, at the Medicare insured patients, which was about 2,000 patients in their model, the cost savings was over $1 million for 2,000 patients tested when they just went ahead and did a panel. And of course, the test results came back much quicker than if they did sequential gene testing. So how would this apply to GI cancer? Well, let's look at colon cancer as a perfect example. I think we could arguably say that these genes here in black are absolutely standard of care for testing in colorectal cancer. I think the others could also legitimately be added on. And when we use the less expensive Medicare testing rate of $400 per test, you still get to about a $3,200 price range. When we compare that to the commercial test cost that Dr. Pennell showed of about $2,800, it's still less than doing individual gene testing for each of those genes. So again, emphasizing the idea that testing with a panel is cost effective and of course time effective as well. But does all of this lead to an actual survival benefit? Well, we're starting to see some of that data develop. And we presented this at ASCO just a few weeks ago. But what we're starting to see is that when patients get appropriately matched, when they have a predicted biomarker, they get appropriately targeted therapy, they actually do better than if we don't treat them with the appropriately targeted therapy. So let me walk you through this example. We're over 1,000 patients tested in the Know Your Tumor project. 677 of them we had longitudinal outcomes information, and we looked at the patients who had actionable findings versus those who did not. There were 189 patients with actionable findings, 46 of whom received appropriately molecularly targeted therapy versus 143 who had actionable findings but did not get so-called matched therapy. We also compared that to the 488 patients who did not have any actionable findings. And when we looked at, again, the gold standard endpoint of overall survival as defined from the time of initial diagnosis, the overall survival for the patients who had matched therapy and who had a predicted biomarker and had matched therapy was a full 1 year greater than patients who had a predicted biomarker but did not get the appropriately matched therapy, and also 1 year greater than those who had no underlying biomarker. So this really emphasizes that we do see survival benefit when the patients get tested and get treated appropriately. So I think that brings me to my summary that we should definitely be testing. First of all, to re-emphasize, actionable mutations are not rare. I looked up the EU definition of rare and it's 0.05%, and I've shown you that finding actionable mutations across the various GI cancers occurs in 10, 20, 30% depending upon the cancer subtype. Testing has become much less expensive and certainly is much less expensive than the therapies we use to treat these patients. So we really have to be realistic about the claim that it costs too much to do NGS testing. And again, as I mentioned, that the testing does reveal actionable mutations, and when these patients get the appropriate therapy, that's a very important point. We have to make sure these patients are treated appropriately. But when they do get the appropriate therapy, there is a disproportionate benefit to these patients with potentially survival benefit, overall survival benefit as well. And so it's in this context that I really praise the NCCN pancreatic cancer panel. When they convened in April, they decided that they were going to recommend universally germline testing for all pancreatic cancer patients. But even for the advanced and metastatic pancreatic cancer patients, they also recommended tumor or somatic gene testing as well to look for these actionable findings. And we know that represents 80% of pancreatic cancer patients. So effectively, the majority of pancreatic cancer patients, if not all, should certainly get germline testing and should probably get tumor somatic testing as well. So with that, I'd be happy to take any questions.